Okay, everybody, I think we can get started now. Again, this is Neil Andrews, editor of PRF. Welcome to today's webinar on the topic of neuropathic pain and skin conditions, to be presented by Dr. Margarita Calvo. In terms of the format today, Dr. Calvo will present a 30-minute talk, followed by audience questions. We encourage everyone in the audience to submit your questions at any time, and you can do that by typing them into the Q&A area of your Zoom window. Also, we really encourage you to join the conversation about the webinar on Twitter and do some tweeting. It's hashtag PRF webinar, hashtag pain research forum. The webinar is actually streaming live now on Facebook as well, and so we welcome everyone who's viewing the webinar that way. So let's get going. I have the pleasure now of introducing our moderator, Dr. Ted Price. Ted is the Eugene McDermott Professor and Director of the Systems Neuroscience Program in the School of Behavioral and Brain Sciences at University of Texas at Dallas, UT Dallas. He's also Director of the Center for Advanced Pain Studies at UT Dallas, and he's also the Chair of the PRF Editorial Board, and so we're really glad to have him here today to moderate the webinar. Ted, please take it away.
Thanks, Neil. It's my pleasure to introduce our speaker today. Our speaker is Dr. Margarita Calvo. She's an associate professor in the Department of Physiology at the Catholic University of Chile in Santiago. This is where she did her medical training. She was awarded her PhD in 2010 at King's College in London, where she worked with Professor Dave Bennett. She went back to Chile in 2013, where she set up her own lab. She's been working on 2 lines of research primarily in her independent laboratory. One of which she'll be talking about today is painful small fiber neuropathy and skin conditions. The other is the role of Kv1 channels in counterbalancing hyperexcitability and neuropathic pain. Her work takes a translational approach ranging from in vitro models to human psychophysics. She's also part of the pain unit at the University Hospital, where she sees neuropathic pain patients. We're really pleased to have Dr. Calvo as our presenter today. Margarita, please go ahead.
Hi, Ted. Can you hear me okay? It's okay?
Yes.
Thank you very much for the invitation. It's an honor to be here presenting my data in PRF webinars. So today I'm going to tell you about what we are investigating on cutaneous pathology. So I'm going to focus on one specific skin condition today, but we're trying to see if they play a role in developing painful small fiber neuropathy. So I hope I'll convince you that some of them, at least this condition, does give them neuropathic pain. Well, first, this question came to our lab because, I mean, if you know about intraepidermal innervation, you know that the small fibers that are unmyelinated fibers cross the dermoepidermal border and they innervate the epidermis. And if you see in that hematoxylineosin section that is shown below in a normal skin, you can see a nice epidermal dermal border where the keratinocytes are in contact with the dermis and the fibers cross in that border. But if we think in skin conditions, you will realize that this anatomy is very much distracted. And we thought to investigate in a specific condition where they have big blisters forming between the dermis and the epidermis. So specifically in that side where the small fibers cross into the epidermis. So we thought to investigate this particular disease, which is called recessive dystrophic epidermolysis bullosa, which is a rare genetic connective tissue disorder. In this case, at least the patients that we see in Chile all have mutations in the gene collagen 7A1. And this is a protein that it's important in the union between the dermis and the epidermis. And this leads to phenotype that it's an extremely fragile skin that will have blisters and will tear from any kind of friction. So here you can see a couple of photos of my patients where you can see that they have big wounds because they have these blisters that the epidermis comes off from the dermis really, and then they have this healing process, and some of the scars are retracted. So you can see this pseudosyndactyl that you can see the hand. They have all the fingers, but the the scars are retracted, so you can see this kind of hands that they have. We decided to recruit some of these patients, adult patients, to see if they actually have pain. I mean, we heard, because we know these patients from before, that they were complaining of pain from the wounds, but also from pain in areas where the skin have already healed, so they were not having active wounds. So we recruited some of these patients. We recruited 29 patients and 27 age-matched controls, and we asked for pain. And we, the patient have in mean numerical rate scale was a 4.2, and our controls, obviously, they didn't have any pain. And we also asked for itch, and they also reported a high incidence of itch. So then we asked if they have pain, and of course, most of them will have pain every day. And they will have acute pain that will localize to areas of active skin blistering where the wounds are opened. And some of them will resolve after healing. But the patients complain, and that's why we did a study, of persistent pain coming from areas of the skin that were already healed, not injured, and especially localized to the feet. And then we find out that also to the hands. So we decided to do some questionnaires. We used the DM4 questionnaire to see if the pain of this patient have any neuropathic characteristics. And most patients, so almost 76% of the patients, scored over 4 points on the DM4, so highly suggestive of neuropathic pain. And then we used the MPSI questionnaire as well, and we found that most of the patients will have burning sensations, tickling sensations, electric shock-like sensations, and pins and needles. This is all on the sites where they are not having active wounds. And so we asked, like, where does it hurt? And in most of the patients, they'll have this pain in the legs. Some of them will have it in the hands, but it will be in some of them only in the feet, then in 50% up to the knees, and in another 25% the pain will be from the feet all the way up to the hips. And the duration of pain was quite variable, so because this patient will have a variable duration of some of them were younger and some of them were older, so the pain will be between 1 to 25 years, with a mean of 4 years. These patients, we did like a very thorough neurological examination, and we found that they have no muscular weakness. The reflexes were present and normal. Some of them were very difficult to get because of the scars they have, but if you can get the reflexes, they were normal. And the sensory fibers of, the sensory function of large fibers was normal. So light touch, vibration, proprioception was all normal. But thermal sensitivity to cool, that was we're testing in the neurological examination, was impaired in 80% of the cases, and it was having a distal to proximal gradient, similar of what we found when we asked for the pain. So it started in the feet, and then you can see some patients going up all the way to the hips. In 16% of the cases, we found this thermal insensitivity in the hands as well. We then test for large fiber function. So we did some nerve conduction studies just to make sure that the large fibers of these patients were normal. And actually we found that the sural nerve and the peroneal nerve that we tested to test for sensory and motor nerves, we found that they were normal. They were the same in the controls than in the patients. And we then did quantitative sensory testing to test for the small fibers on these patients that we thought that they will be the ones that are being injured because of the blisters were on that side. And what we found is, this was the first time we were doing quantitative sensory testing in Chile, so we had to do control patients to compare them to the normative value of the DFNS. And control patients were all normal. There was all values were the same as in the DFNS, except from the MPS, which is a mechanical pain sensitivity, which was quite high in our population. We don't know why, but patients in Chile, volunteers in Chile will score higher the in the numerical rate scaling of a pain stimulus that we're giving, higher than the normative data in the DFNS. Apart from that, it was controls were normal, but patients with RDEB, we found that they have impairment in sensitivity to thermal stimulus. So they will have a cold detection threshold, a warm detection threshold, and a thermal sensory limit. You can see here that they were decreased compared with a control population. They also have some sign of a gain of function, so they have the mechanical pain sensitivity even higher than our controls, and the wind-up ratio was also a bit higher. This is a foot of a patient showing where we did the quantitative sensory testing, and then later on where we get the skin biopsies, and you can see that it's we did it in the area of normal skin, although it's skin that it already had an injury, so it's scar skin, but not in active wounds. And from these patients, around 17% of them show dynamic allodynia. We took a skin biopsy from the 10 centimeters above the external malleolus, and we did immunohistochemistry and stained for PGP 9.5, which is a marker, a pan-neuronal marker. So we will stain for any kind of axon that you can find. It's a well-defined technique, and you can actually determine how many fibers are there in the epidermis. So you count, the staining will show you all the fibers, and then we can do the line where the dermoepidermal border is. For that, we use a DAPI, and we can define the border. And then you can count the fibers that are crossing into the epidermis. So for control patients, we have the same as it have been previously reported in the literature, so around 15 fibers per millimeter. But in our patients and our RDEB patients, we find no fibers crossing into the epidermis, really. So very few fibers crossing. So if you compare the controls with a RDEB patient, you'll see, sorry, I have the star is missing here, but there was a significant difference. And then between our patients, because there was a big variability between how the disease presents in these patients, we use a questionnaire, which is a Birmingham EB severity score, and gives you an idea of how severe the RDEB is in that patient. And we correlated that score with the score that the number of fibers they have in the epidermis. And there was a correlation. So the worse the RDEB in that patient, the less fibers they will have in the epidermis. Then, because, this seems to be a small fiber neuropathy, so I thought, well, is this affecting the autonomic fibers, which also are C fibers or unmyelinated fibers? So we did, I think I didn't put it here, but we check for dysautonomy in patients, heart rate variability and blood pressure variability, and we found no difference. But then we thought, well, let's look out at the autonomic nervous system in the skin, directly in the skin, to see if that's impaired or not. So first of all, we did this sweat skin response, where you record from a patient if they have a sweat response after a stimulus, and you can see here in A are our controls, and here are the patients, and you can see that a normal patient, when you do something that gives them a stimulus, such as they're lying on a bed and we clap very loudly all of a sudden, and they'll have a sweat response. But EB patients will not have any kind of sweating response to that. We quantify this response, and the EB patient will have a much lower response than the controls. And then we decided to look at sweat glands in the skin, in the dermis. Actually, they are deeper into the dermis, and we stain for DAPI, which will see all the nucleus, and you can see these nice sweat gland formations in there. And we did PGP staining to look for innervation of these sweat glands. And you can actually see that the control patient will have nicely innervated sweat glands, but the EB patient will have some innervation, but very little. And we also look at these TS31, which is a marker of endothelial cells, to see if blood vessels were also being less innervated. And I mean, in the images, we thought it was less, but when we did the quantification, we found no significant difference in the blood vessels, but a big difference in the sweat glands. So there was some autonomic nerves dysfunction, at least in EB patients. So we said, okay, if we look at the NUPSI grading system to see if these patients are suffering from neuropathic pain, we know that they have pain, but we wanted to know if they have neuropathic pain. So we use the NUPSI grading system, and you can actually see, yes, this patient have pain, but if this pain have an anatomical plausible distribution, and yes, our patient will have a length-dependent pain, so it does, yes. And if the history suggests any lesion or disease to the nervous system, yes. So we have this damage to the skin that actually is where the small fibers of the skin are. So we follow this paradigm, and we have a possible neuropathic pain. And then we go on to the examination, and we found positive sensory signs confined to the innervation of the lesion nervous structure, yes. So we found that in the QST and the clinical examination. And we have this diagnosis test confirming the lesion because we have the skin biopsy. So in most patients, we have a definite neuropathic pain diagnosis. In some patients, we did not have the skin biopsy because they refused to have the skin biopsy. So in those, we have a probable neuropathic pain diagnosis. And in a few percentage of patients that they came with a diagnosis of RDEB, they did not have any pain. So if they don't have pain, they don't have neuropathic pain. So at least with this, we can confirm that the patient that had pain, most we have a definite diagnosis of neuropathic pain. So the next question was, okay, if these patients are suffering at least from some neuropathic pain, can we treat these patients with the usual drugs that we use to treat neuropathic pain patients? So far, these patients were being treated with opioids or anti-inflammatory drugs, but nothing specific to neuropathic pain. So now we are starting a randomized clinical trial, which is a crossover trial. It's been run in 2 centers, so in Canada, in the Sick Kids Hospital, and here in Chile, trying to see if pregabalin can help or can give any pain relief to these patients, being pregabalin one of the first-line drugs for neuropathic pain. So what we're going to try to look is at reduction of numerical rate scaling on pain, and we're also going to look at itch. And our secondary outcomes will be satisfaction on pain and itch relief and quality of life. So we're doing a placebo-controlled SI, and it's going to be crossover. So all patients will receive placebo or pregabalin, and then they will receive pregabalin or placebo. And then we'll see if pregabalin is any better than placebo, at least in this population. And then at the same time, we're asking ourselves, what are the mechanisms of this painful small fiber neuropathy in RDEB patients? So for investigating this, we have a model, an animal model of RDEB. So these are the hypomorphic mouse. These are collagen 7A1 mutants. And you can see actually that these animals develop this very characteristic pseudosyndactyly that they have in the hands, the humans. So this is a patient, and you can see when it's born and then how he ate, they develop this pseudosyndactyly, so this scar, a retracted scar, and you can see that the animals will develop the same kind of scars. They don't present collagen 7, it's only in 10%, it's expressed in 10%, and you can see that these animals are smaller than the littermates, and they have similar phenotype than the patients. So first of all, we wanted to see if these animals have the same small fiber neuropathy that we found in the patients. So we did skin biopsies, and we stained them for PGP 9.5, and we saw in the littermate controls that we have nice innervation of the epidermis, but this was actually very low in the mutant animals. So if you do quantification, you can find a significant decrease in innervation in the mutant animals. We try to define which fibers are the ones that are lost. So if they are peptidergic or non-peptidergic fibers that are missing. And so far we have done the staining for CGRP, so peptidergic fibers, and we found a decrease in these kind of fibers. But we have not been able yet to do a nice staining of the non-peptidergic fibers. Also, we wanted to look at the sensory profile of these animals. So we did some behavioral essays, and we looked for mechanical sensitivity using the foam fray filaments, as is shown in here. And we saw that this, sorry, this is in Spanish, but the mutant animals, or the hypomorphic mice, they will have the same sensitivity that the controls, the legitimate controls, but they will have a less thermal sensitivity than the legitimate control. So we put them in this thermal place preference, where the animals are at 25 degrees or 50 degrees, and they can freely move between these two plates, and we can record that, and we can see how much time they spend in each of these plates. And we found that the mutant animals did not avoid the 50-degree plate, so they will not feel any pain in that plate. We did a Hagreth test where we use a laser to evoke thermal pain in the pose, and there was a trend to significance, but we don't have a significance yet. But this, I mean, I have to say, these are only 5 animals, so we're still increasing the numbers. We're trying to look at the sciatic nerve to see if the small fibers and the large fibers are the same or different in these animals. This is data that it's now being analyzed, but we use electron microscopy, and we have seen that both the mutant animals and the control animals will have nice morphology of the C fibers and of their large fibers, but we have seen that in the mutant animals we have seen lots of infiltrations of these cells that are macrophages. So we have to analyze and see if that's the case or not. We look at the DRG to look at different peptidic and non-peptidic expression in the dorsal root ganglion, the sum of these cells, and we found that control animals were the same as the mutant animals. So there was no decrease of any kind of markers of sensory, of small fibers in the dorsal root ganglia, and we didn't find any difference either in the spinal cord. So we're looking at the central terminal afferents of these sensory fibers coming to the spinal cord, and we did staining for peptidic and non-peptidic fibers, and we found that it was the same expression in control animals than in the mutant animals. So far what we think is going on is that these patients are having, so this is skin of the patient, so this is just to show short axons and long axons from the legs, or short axon from the thorax, for example, or the skin is having these big injuries, so the big blisters, and this is causing a degeneration of the fibers in the skin in any place of the body. And after the lesion is gone, after the injury is gone, these fibers will grow back into the skin if they are short axons, but they will have a problem in regrowing back into the skin if they are long axons. So that's why we're seeing a small fiber neuropathy that is length dependent. And now we are trying to investigate why are these fibers not regenerating into the skin? If there is any problem or dysregulation on the neurotrophic factors that should be expressed by the skin. So the first thing that we did is that we took some skin samples and measured with a qPCR the expression of different neurotrophic factors. And well, before showing this, actually, what we did is we did a lesion and we measured neurotrophic factors, and there was a very, very low expression of these factors. So we decided to do one biopsy, and then 10 days after that biopsy, take another biopsy from the same side. So then we're doing an injury to the fibers in the skin, and then we're measuring what's the response on neurotrophic factors after an injury. And you can see that control patients or volunteers, they will have a big increase in GDNF and NGF in the skin, as expected, because these are neurotrophic factors that are important for regeneration of small fibers. But the EB patients, after having the lesion, they will not have this response in GDNF or in NGF. We also look at the receptors of the neurotrophic factors, and we actually did not find any significant difference in any of the TRAC or receptors or the GDNF receptor. We also did P75, which is not here, I don't know why, but it didn't show any difference either. So now I'm thinking, well, maybe it's that keratinocytes that are the ones responsible for secreting neurotrophic factors are altered or somehow not doing what they should do in these skin conditions. So this is very early work. We are just, first of all, trying to optimize essays in a human keratinocyte line. And we are trying to do a wound healing essay. So to somehow stimulate and activate the keratinocytes to secrete the neurotrophic factors that they should do. So this is the essay, and what we are doing is that we're taking the conditioned medium from these keratinocytes, shown in here. We're taking the conditioned medium, and we are putting it into DRG explants and looking at axonal growth. And this is, I mean, very preliminary data. It's only N of 2 animals, I think, or very, very little. But we have seen that if you give the conditioned medium from the keratinocytes, you see a better growth of the axons if you measure it by PGP, which is here, or if you measure it using acetylated tubulin, which is here. So these are experiments that we are running now, and we hope that we soon will be able to do this, but with keratinocytes, primary cell cultures from keratinocytes extracted from the skin of our patients. And we are also doing this essay where we do an axotomy of the DRG explant. So we cut the axons of these DRGs, and then we put the conditioned medium from the keratinocytes or normal medium. And you can see that also there is trend, because it looks like lots of points, but these are only 2 different cultures, but lots of wheels. So we don't have any significance yet, but you can see that the fibers seems to grow better after you put the conditioned medium from the keratinocytes cells. So this is work in progress. So now, I mean, the idea is to measure the growth factors, neurotrophic factors that are being secreted from the keratinocytes in this conditioned medium after being stimulated, and we plan to do DRG regeneration assays using keratinocytes, as I said, extracted from our patients and from controls, and not just from a cell line. So yeah, I think, I'm not sure how we're doing with time. Yeah, just the 30 minutes.
Yeah, you're exactly.
Exactly 30 minutes. So this is my lab. So these are the people working and all my different collaborators. So David Bennett, that works in Oxford, and different people in Chile and in also Germany and Canada that have been working with us in this project. So I think it's time for questions.
Yep. Thanks very much, Margarita. We have a number of questions, so we'll jump right in. So the first one is, what do you use right now to treat pain in the RDEB patients? Are you using gabapentin based on the discoveries you've made about their pain likely being neuropathic?
Yes, I mean, that's a good question. When we started this project, patients were all in paracetamol or maybe some anti-inflammatory drugs for short periods. But when we found that this was actually neuropathic, we started treating them with we could do amitriptyline. We thought it was a good option, but there are some reports that this patient may have. I mean, there's one report in the literature that one RDEB patient have heart problem after taking amitriptyline. So it's that, well, we prefer to be safe, so we use pregabalin, and we have we had in a few patients that we were treating a good response. So that's why we decided we should do a proper clinical trial to be sure that pregabalin is going to work with them. So yeah, so far we're using mainly pregabalin, and in some patients we're using duloxetine as well, because some of them will have associated depression as well. So it could be a good medication.
Okay. All right. Next question from the audience is: I'm surprised by the lack of effect on patients' hands. For a purely length-dependent neuropathy, I'd expect a stocking glove distribution. Considering the huge areas covered by the L4 and L5 dermatomes, is it possible that pathology tracks more closely with dermatome area than with length?
Yeah, I mean, that's a good question. I mean, mainly why we're not seeing this neuropathic, I mean, we are seeing this neuropathic pain in the hands as well. But in the hands, because they use them more, they are more exposed than the feet, I guess. They have more active wounds. So it's a bit more difficult to define if the pain is neuropathic or is actually inflammatory pain from the wound. So we have, I mean, the data over there, I think, is more confusing. So I'll not say they don't have pain in the hands. They have pain, but we don't know if it's neuropathic or not. So I assume actually that it's sock and glove distribution, length-dependent distribution, but it's difficult to see it in the hands. But I mean, that's something we still have to look at in more details, I guess.
Yeah. Okay, another question from the audience. The pathology looks amazingly like painful diabetic neuropathy. Does the loss of collagen 7 cause any changes in insulin or glucose control that could contribute to the neuropathy?
Yeah, that's a good question, actually. I mean, it looks like a diabetic neuropathy, or looks like any small fiber neuropathy length dependent. So you always have this, it's a thermal hyposensitivity, pain, and reduction in intraepidermal nerve density. So I think, I mean, what I have seen is that this collagen 7A is very specific to the dermoepidermal border. We didn't see it at first in any, I had a look in neurons and couldn't find that it was expressed there, but now there's some new mRNA data that suggests that it might be in sensory neurons. But I mean, the difference with this neuropathy, with the diabetic neuropathy, is that this is exclusive to small fibers. That diabetic neuropathy starts with small fibers, but then as the disease progresses, they will have problem in the large fibers as well. In this case, it's solely small fibers. We did not see any patient with large fiber involvement.
Yeah. So. Kind of related to the first question, have you looked at how skin in the patients without pain differs to the skin of the majority of patients with pain?
Well, yes. I mean, we have very few patients without pain, and they didn't want to have a skin biopsy, so that was difficult because we could not compare the pain with no pain. But I have to say, I mean. This patient that didn't have pain at that time, so this study was done a couple of years ago, and now we're still recruiting patients to look at the neurotrophic factors, and we have seen that this patient actually with time they develop pain. So maybe it's just a matter of how bad is the RDEB disease being. So that's why we did this correlation with Birmingham score to see. Maybe is how severe the disease is. It depends on how soon you present with a small fiber neuropathy. Mm-hmm. So, but we don't have the skin of patients without pain. There were quite few, and they refused to have a biopsy if they didn't have any reason to have it.
Yeah. So, in one of your early slides, you showed that itch is quite prominent in this particular population. Could you comment a little bit about the mechanisms that might be underlying itch in this population?
Yes, yeah, thank you. That's, I think, I mean, when that was a surprise, actually. We're looking for pain, but but the patients were complaining of pain and itch. They will tell you straight away that they were having lots of itch. And it was at first, I mean, we recorded the data because they were saying they had itch, so we asked them and we recorded it. But the itch will come from the inflamed areas of the skin, so where they're having active wounds, as well as from the feet and from the hands. So that was a bit confusing because at first we thought, okay, it's all related to the wounds. But then we realized it might not be related to the wounds, but might be neuropathic as well as the pain that we are finding. And we know that it comes from the same sensory afferents than pain, so from small and myelinated fibers. They are supposed to be different receptors and to have different pathways, but they are in the epidermis as well. So it's not a surprise that if we are seeing neuropathic pain from this condition, we might also be seeing neuropathic itch, and that's why we start asking for that, and we decide to ask for it in the clinical trial as well, because we have the idea that if pregabalin works for the pain, it should, or maybe it can work for the itch as well, thinking that it could be neuropathic itch.
Given that this is a skin disorder, or at least a connective tissue related to the skin disorder, can you use topical therapeutics on these patients?
Yes, so that's a bit of the idea. So it's all in the skin only. It's not. I mean, they have in the how you say, the internal mucosa. They will have a blisters as well.
Okay.
But I mean, the neuropathic pain, it's coming from the skin really. And the only problem is that if you we thought of using lidocaine patches straight away because they can block the areas where they're having the pain. But the skin is very fragile. So if you put a patch on, you cannot actually, when you take the patch off, you have all the skin coming off as well. So then we had one patient that we put a patch, and then there was a big wound coming when we took off the patch. So after that, we have been trying the physiatrist in our center. He has been trying with these special things that you can remove the adhesive from the patches. So you can actually sort of dissolve the adhesive before removing the patch. Mm. And that has worked. But it's also a bit painful because it's based on alcohol. So it's painful when you apply it. So, I mean, we have not been able really to use any local treatment. Lidocaine creams we thought of, but because they have, I mean, it's quite complicated because they have wounds as well, so you don't want the lidocaine to be absorbed systemically as well, so it's a bit complicated. But, I mean, what we're planning to do, and if everything works fine, I mean, if we could find, for instance, some neurotrophic factors that are not being secreted there, and we could give a topical cream or a topical treatment that can actually activate the neurotrophic factor receptors to make these fibers grow back into the skin. That's the aim. I don't know in how many years, but that's what we are looking for.
Okay, next question. So if you compare the QST profile that you have in the RDEB patients with some of the profiles that you see, like for instance from the German neuropathic pain QST profiles, do these patients fit with any particular phenotype, for instance, the irritable nociceptor phenotype? And does this tell you anything about therapeutic approaches that you might want to take?
Yes, I mean, that's, yeah, I mean, when we were doing this study, the study of the DFNS and the clustering phenotypes was, I think it was done just before, or so I look at our data afterwards, and yes, so our patients do fit into this called mechanical hyperalgesia phenotype. So they're having thermal hyposthesia and mechanical hyperalgesia. And if we look at this specific cluster, to what kind of a treatment they respond, they should respond to pregabalin. That's what they it's one of the drugs that should work. So that's why we decided to use pregabalin for the clinical trial, based on that paper, of that clustering paper.
Yeah. Okay. Next question. So how willing do you think the RDEB patients will be to give skin samples for primary keratinocyte isolations? And if you can get these, will you take them from hairy or glabrous skin? And do you observe differences in sensitivity in RDEB patients in glabrous versus hairy skin?
Yeah, we have not done a comparison between, I mean, we always do glabrous skin, not hairy skin. I mean, I have to say, they have very few places where they have hair anyway, because part of this is, these scars are devoid of any hair. So it's mostly glabrous skin, I guess. But we have not looked at that particularly. And I think for the skin biopsies to then culture the keratinocytes is a bit tricky, because we are first trying to optimize all our assays in a cell line, so it's easy and we have lots of the cells and it's no problem. And at the same time, we're trying to grow keratinocytes from biopsies. And we have found that a 3 millimeter biopsy is quite small, so you need a long time to get confluence of the cells in vitro. So, I mean, we are actually now working with skin from abdominoplasties, where the people, I mean, they have these surgeries where they have all these big pieces of skin being removed, and we use them to optimize our keratinocyte cultures to be able to have as little as possible, to start with as little as possible, and then be able to grow the keratinocytes. Anyway, we're working with a DEBRA charity, which is a charity that looks after these patients, and they're trying to build biobanks of keratinocytes from their patients. And so far they have keratinocytes that have been cryopreserved for 5 or 6 patients, I think now. So, I mean, we're working with them, and we hope that we'll be able to get enough cells from the patients.
Mm-hmm. So, in relation to the skin samples that you've obtained from the patients, have you considered doing any investigations into phenotyping the immune cells that are infiltrating into skin?
Yes, I mean, that's something we need to do. Well, because they have a big inflammation in these patients. They have all the time they have inflammation. So I guess, so we're trying to look at keratinocytes, but we also would like to look at, well, fibroblasts as well, because they can secrete neurotrophic factors. And we're going to look at immune cells, because specifically macrophages, when they are activated in inflammation, they can also secrete neurotrophic factors, and they could be, or they could secrete, I mean, I guess they are secreting all these cytokines, inflammatory cytokines that are promoting degenerations of the fibers. And I mean, that's for sure, but what we want to look is at regeneration of these fibers, why they're not regenerating. So we would like to look at, I mean, all the cells in the skin that they should promote regeneration and why they're not doing so.
Okay. So sticking with so sticking with the keratinocytes and or immune cells, if it turns out to be the case that the keratinocytes don't have much involvement in neurotrophin secretion, what other candidates would you imagine looking at for your neurotrophin hypothesis?
Yeah, so I mean, just having a look in the literature, most cells, I mean, normally in the skin there is a very low basal neurotrophin factors release, but they're very little. But after inflammation or after activation, you can have different cells secreting neurotrophin. So keratinocytes can secrete all the neurotrophins, but also melanocytes can secrete neurotrophins, although, I mean, they really are a very low population of skin. They're only like 5% of that cell. So it'd be a surprise that all that regeneration will depend on melanocytes' production of neurotrophic factors. But other candidates are fibroblasts, which when they are activated, and especially when they're transformed to myofibroblasts, they can secrete neurotrophic factors. And in this case, in these retractive scars, you can see lots of myofibroblasts. So that could be an important candidate. Although they are in the dermis and not in the epidermis, but maybe they're still having a role. And immune cells. We plan to look at macrophages as well. So we have this idea, we have blood samples from the patients, and to start with, we will try to look at, we will take the monocyte portion in the blood, and we will grow cultures of these monocytes and try to differentiate them into macrophages, and then see if we activate them, if they can secrete neurotrophic factors or not. So that's something we are planning to do.
Yeah. So coming back to the C fibres now, do you have any evidence, or have you looked at any particular molecular pathologies that are ongoing in the small fibers? In particular, that the question is there any evidence that there's changed chloride concentration in these C fibers in RDEB that might lead to changes in presynaptic inhibition, for instance?
No, that's a good question. No, so I mean, most of the study that we have done so far, it's in the skin of the patient, so we didn't have the sensory neurons. But now we are having this animal model, which has been a bit tricky because these animals are quite severely affected by the disease, so it's difficult to grow them. So usually the mother kills them first, and then you have to try to separate them, and then we have few animals, so that's why we're showing the data on 5 animals, I think. But now that we have the animals and the colony is running, we're planning to do all these assays, and particularly to look at the sensory neurons that we cannot directly look into the humans. So we plan to do the IgE explants and to start investigating all the pathology in the C fibers.
Okay, so also with relation to C fibers or fibroblasts or keratinocytes for that matter, that there are many different types of collagen, and collagen 7 is just one of them. So the loss of collagen 7, do you know how it particularly affects the cells other than the phenotype that you see? And related to that question, are there any compensatory changes that happen when you lose collagen 7?
Yeah, I mean, mainly what it has been investigated is that when they lose this one particular collagen, of course, I mean, and some other RDEB patients who have different mutations and the phenotype will be different, but in our cohort of patients, they all have this precise mutation. Well, it's different mutations, but in the same gene. And I mean, what seems to happen is that they lose this collagen 7, so that the basal lamina it's loose, and you can have these big blisters, and that induce inflammation. And these patients will have all the time, they're very inflamed, so they have a high protein C, how is it in English? Sorry. So they have evidence of inflammation. And I mean, the keratinocytes, I don't know, but they express lots of TGF-beta, so that's very high in these patients. And they're supposed to be all the time proliferating. So the skin, they have hyperkeratosis, so a very thick epidermis, because they're proliferating all the time. So that kind of equilibrium between basal keratinocytes and keratinocytes that are being lost in the layers of the skin, it's gone. So they have lots of keratinocytes being proliferating. And fibroblasts, because of the scars, they turn into myofibroblasts, and they are quite different as well. So, I mean, they're all changes that occur as a consequence, I would say, of these blisters coming on all the time, chronically appearing in the skin. But I mean, that's all what I know to answer the question.
So, there was another question that popped up while you were answering that. So, and it's related. So, is there any evidence that there are particular types of keratinocytes, for instance, K14 versus K17, that are playing distinct role in small fiber neuropathy that you see here?
Yeah, actually, I don't think there's any evidence of, in this case at least, in RDEB, but it's a good question. I mean, and we could look at that as well, because yeah, it's a good point.
All right, last question. Does age or sex contribute to the neuropathic pain that you're seeing in this population?
Yeah, I mean, there are not too many patients, so this is a very rare disease. So we have about, I think there are 60 patients with this genetic mutation, and from them, many of them are children. So we tried, because we're doing biopsy and we are doing quantitative sensory testing, we wanted to do it in adults, not so much in children. So we ended up with 29 patients, and we test almost all of them. But that's not enough to say if there is any difference in sex, because it's difficult to say. I will say the same. I mean, it's very similar. I have not seen any difference just by seeing the patients, but definitely there is a difference with age. So when the children, they have pain in the wounds, but they will not have this neuropathic pain or itch that will be so annoying for them. So, but with time, and it depends on the severity of the disease that you have, when will it come? But it comes. So all the patients that they have pain when we did the initial study, now they have pain because it has been a couple of years. So it kind of developed with, and it depends on age and years of disease and severity of disease.
Well, Margarita, thank you very much for a really terrific presentation. Thank you, audience, for really a lot of questions. Obviously, there's lots of interest in the work you're doing, so thank you for the presentation, and thank you for all the great answers to all the very stimulating questions. So now I'm going to turn it over to Neil to close out today's webinar.
Thanks, Ted. So as we wrap up here, on behalf of PRF, I'd like to echo Ted's thanks to Margarita for her really fantastic talk today. Thank you so much, Margarita. I also want to thank Ted for doing another wonderful job of moderating. Thank you, Ted. And we also thank all of you, all the attendees, and for all of you for listening to the webinar and for submitting your questions. A couple of final notes. We're going to have a recording of the webinar available probably by the end of the day today on PRF. So if you'd like a replay, or if you have colleagues who might like to listen but couldn't attend, you'll be able to access the recording shortly on PRF. The recording will also be available on the PRF Facebook page. And finally, save the date for the next webinar. It will be on August 13th at noon Eastern. The topic is going to be dorsal horn pain circuitry, and it's going to be presented by Andrew Todd. We'll have more information about this webinar posted soon on PRF in July. So with that, we hope you enjoyed the webinar today, and we look forward to seeing you at the next one in August. Take care. Bye-bye.
Thank you very much. Bye-bye.
Thank you.